In this episode, we will turn our attention to some of the differential diagnosis of noisy breathing in children, with focusing on epiglottitis, bacterial tracheitis, and croup. Beginning with epiglottitis, I would like you to pay attention to the differentiating features between these three conditions. What's the common age for epiglottitis? 3 to 7 years. What are the common presentation symptoms and signs? Usually an unvaccinated child with toxic exposition such as high fever, restlessness, tachypnea, as well as muffled or hot potato sound of breathing, and stridor that is inspiratory. There is also stiffness of the neck and this position that's referred to as the sniffing position or the tripod position, as the child prefers sitting up while holding the neck on extension. And while dysphagia and drooling and stridor are possible, hoarseness or cough are not the significant findings. Are there exceptions to these rules? Yes. In adults, we usually have less toxic manifestation with milder non-toxic presentation, sore throat being the most common presentation, as well as anterior laryngotracheal tenderness. Which one of the findings indicates severe airway obstruction? Possibility of stridor, respiratory distress, tripod positioning, or even dysphagia and drooling. Now, what are the common underlying pathogens? Haemophilus influenza B followed by Streptococcus pneumonia are the most common. However, in immunocompromised patients, it's possible to be vaccinated and have epiglottitis with atypical pathogens or even with fungi. Now, a very important true or false question at the very beginning of our approach to epiglottitis is: true or false, the very first step in approaching a kid with symptoms suspicious of epiglottitis is examination of the airway and taking an IV line? Well, many of you who know the general flowchart of approaching through emergencies such as epiglottitis would agree that we need to follow A, B, C, D, E, and the C circulation requires IV line assessment and taking an IV line for IV fluid. However, in the case of epiglottitis, we should avoid any kind of maneuver or intervention that makes the patient uncomfortable before assessment of the airway maintenance. For the same reason, and I'm sure much higher number of people know this second fact, we should avoid any maneuver or any attempt to visualize the airway initially, such as use of tongue depressor. Even furthermore, we should even avoid unnecessary physical exam maneuvers. Based on this, what is the very first decision point question approaching a child suspicious of epiglottitis? Assessing the availability of a patent airway. That's if the patient is able to maintain the airway open. Based on this, we have two scenarios. One is the patient who can't maintain airway open, and that is a patient in respiratory distress or is suddenly deteriorating. And what is the next step in that patient? We initiate bag valve mask ventilation and evaluate O2 saturation response to this attempt. Once more, true or false, a child with symptoms of epiglottitis is suddenly deteriorating. True or false, the next step is rapid sequence intubation. That's false. We need to first provide bag valve mask and measure the O2 saturation response. Why is it so? Given the fact that the patient most of the time would need endotracheal intubation. That's because epiglottitis is one of the conditions that's classified as difficult intubation, and we need to figure out if we have time for elective operating room intubation as opposed to the emergency department intubation, which will be much more risky. Okay, so we provide bag valve mask ventilation and we measure O2 saturation. We will have two scenarios. In the scenario number one, the patient is able to maintain O2 sat on high 80s, more than 88 to 90%. What is the next step? In this step, we move on with elective intubation in the operating room, informing the anesthesiologist or ENT team for that, while continuing our bag valve mask ventilation. The second scenario is, despite providing bag valve mask ventilation, the patient is not able to maintain O2 saturation in the high 80s, and the other scenario is the patient O2 saturation was in high 80s or 90s but is dropping. What's the next step for the assessment and management in this scenario? In this scenario, we perform an emergency department rapid sequence intubation. What's always needed when we attempt rapid sequence intubation? A backup plan such as a surgical airway should be available in parallel while we attempt RSI. What is the preferred method of intubation? Video laryngoscopy. Okay, we are not yet done in this category of deteriorating patients requiring intubation. If the first attempt of intubation fails, what is the next step? The next step is cricothyrotomy based on patient age. Always remember, in patients younger than 12, we perform needle cricothyrotomy, and in patients older than 12, we can perform surgical cricothyrotomy. And that's because of the higher rate of comorbidities and complication in younger kids in cricothyrotomy if it's done through surgical approach. Okay, we are done with the approach to the patient who is not able to maintain the airway. So we are dealing now with the second category, and that's the patient who is able to maintain the airway. What's the next step in this case? In this case, we provide O2 supplementation, not necessarily through bag valve mask, and we attempt chest x-ray. Always remember one rule of chest x-ray in epiglottitis, and that's the controlled setting should be available, possibility of patient deteriorating should be considered, and it should be preferably done in the emergency department. Now, if x-ray is positive, what are the findings? The famous thumbprint sign is one of the findings, but we could also have extension of hypopharynx or loss of valvular airspace. If you hear any of these, distension of hypopharynx, loss of valvular airspace, or thumbprint sign, that's simply marked enlargement of the epiglottis. These confirm the diagnosis. True or false? Diagnosis of epiglottis requires chest x-ray confirmation. That is false. What is the confirmatory test for epiglottitis? It is direct laryngoscopy. Now, it's a very important scenario here, and I would like to frame it in a true or false question. True or false? None of the patients who are able to demonstrate ability to maintain the airway open require intubation. That is false. Is there any scenario in which the patients who are able to maintain the airway open but still require intubation? Yes. What are those scenarios? Any patient with clinical suspicion of epiglottitis who is 6 years or younger, or the x-ray, even in the stable patient, shows more than 50% obstruction of the airway, or if the patient is deteriorating or toxic in general, even if he's older than 6 years and less than 50% obstruction and initially demonstrate ability to maintain airway, these patients still need intubation. Another scenario in the maintained group, in the stable group, is that chest x-ray is not diagnostic. What would we do? If chest x-ray is not diagnostic but the clinical suspicion is high, in other words, we have high pretest probability, clinical probability, we still have to perform laryngoscopy, the confirmatory gold standard test. Is there any contraindication in this approach? Yes, if the patient has cyanosis or respiratory distress, we usually do not want to perform laryngoscopy unless if the patient is in the operating room. Another very important scenario is the patient who is stable and has patent airway, and the question is, we haven't seen the specific findings in chest x-ray, but the clinical probability is low. How do we approach for the management of this patient initially suspected of epiglottitis for some of the findings of epiglottitis. If both clinical suspicion is low and there is no finding in chest x-ray in the stable category of patients, we treat them similar to treatment of croup, for example, with racemic epinephrine or cool mist, etc. And finally, in both stable or unstable groups, regardless of whether or not we perform intubation or any other surgical airways, we need to perform secondary tests for assessment of etiology. And so what are those tests? We perform culture from both epiglottal region and blood culture. Now, what are the rules of antibiotic treatment for epiglottitis? We need coverage of Haemophilus influenza and Staphylococcus. Staphylococcus coverage requires culture to figure out the resistance pattern. So what are the antibiotics recommended for empiric treatment covering Haemophilus influenza? Third generation cephalosporins such as ceftriaxone or cefotaxime. What about indications for vancomycin added to this regimen? If the patient has sepsis or if the culture shows MRSA, we logically add vancomycin to the regimen. What's the alternative to vancomycin? That's clindamycin. What about the post-exposure prophylaxis? Remember, post-exposure prophylaxis is indicated for unimmunized closed contacts. Now, in the country like United States, that the closed contacts could usually follow the vaccination recommendations, the unimmunized people are limited to 2 or 3 groups. One is a child older than 4 years who has not completed the vaccination series for Tdap, or the child younger than 12 months who has not perhaps initiated even the first dose of vaccination. And the third group are any child younger than 18 years with immunodeficiency, any child or adolescent with immunodeficiency. These 3 groups of people require chemoprophylaxis if there are close contacts. What is the antibiotic? You can use rifampin for post-exposure prophylaxis. So once more, always categorize the patients into the stable versus unstable groups based on the ability to maintain the airway. If the patient is stable, perform chest x-ray. However, if the patient is still younger than 6 years or have more than 50% obstruction on x-ray, we still need to perform elective intubation. On the unstable category, we begin oxygenation with bag valve mask and assess the O2 saturation response. If it's less than 88% or if it's dropping, we need to perform rapid sequence intubation with a backup plan available. If the patient, however, is able to maintain the oxygen in the unstable category, we perform elective operating room intubation. If the first attempt fails, we can attempt an emergency room cricothyrotomy based on the age. If it's younger than 12, it should be needle cricothyrotomy. At the end, we have to perform cultures and treat the empiric antibiotics for coverage of Haemophilus influenza and Staphylococcus. Thank you. This is our discussion of epiglottitis.